The last one, the third one, is synovial hemangioma. Synovial hemangioma is anywhere in the body. When you have hemangioma you're worried about, the thing you should be looking for is fat. If you see fatty signal lesion with low tubular structures passing through it, you should be worried about hemangioma. That stands good for very good location of for this etiology there. This is a chondroid lesion, and on imaging it looks like a second patella. So it may be partially or completely ossified, and it has signal characteristics similar to cartilage there. Then I'll skip to talk about just finish with the ligament and the medial retinaculum gets toned. And the second part is the relocation part. The relocation part is when the patella tries to come back to its normal position. It is not that simple for the patella to come back to its normal location. When the patella tries to come back to its normal location, it impacts against the lateral aspect of the femoral condyle. So that's why you get a classic confusion pattern between the medial patella and the lateral femoral condyle. And it is not uncommon to find intraarticular bodies is again within the anterior intercondylar notch. So if you have a case of patellar dislocation, go back always to look for intraarticular bodies, either cartilaginous or bony fragments in the suprapatellar pouch or within the anterior intercondylar notch. With that, I think my time is up. I'd like to thank you for the opportunity. Again, I'd like to thank the organizers, especially Dr. Ismail, for his, for the hospitality. It's been a pleasure to be here. Thank you, everyone.
So, thank you about anything. But here is Dr. from hospital in Amman.
Good afternoon, everybody. In the next 20 minutes, I'll be talking very briefly on the normal meniscal anatomy, the normal variants that can mimic meniscal tear, a pitfall which can form a pseudo tear appearance, the types of meniscal tear and their MRI appearance. So the aim is to recognize the normal anatomy and the anatomic variants in order to ensure diagnostic accuracy and to prevent unnecessary surgery. To identify the meniscal tear on MR images as it's the best radiological modality of choice, and to describe and classify the tears according to their various types, longitudinal, horizontal, radial, root, complex, and displaced meniscal fragments. Meniscal injury is one of the most frequently occurring in it's located between the femoral condyle. It aids in stabilizing the knee, lubricating the knee joint, and the posterior horn of the medial meniscus being the shock absorber and the weight-bearing portion. The lateral meniscus, as we see in this diagrammatic view, is C-shaped compared to the medial meniscus is more of a semi-lunar U-shaped. Each one has an anterior, posterior horn and a body, and with a root attachment. Its primary avascular structure, the main supply is from the peripheral branches of popliteal arteries. We have the red zone, which is the outer 1/3, and the inner 2/3 is the white zone. So since it's avascular, the red zone, so if tears occurred along the peripheral portion, if a small tear, we can suspect a good healing and a good prognosis compared to the inner one. For the normal appearance in medial meniscus, of course, it's best seen on the sagittal PD images. We have the anterior horn, posterior horn of the medial meniscus. It's of triangular in shape, smooth outline with a sharply pointed free edge. It's thicker along the periphery where it attached to the joint capsule and where they have the root attachment. And the posterior horn is usually larger than, it is larger than the anterior horn. If it's similar or smaller inside, you should suspect a recurrent tear or a previous partial meniscectomy. And on the coronal, the medial meniscus is firmly attached to the MCL. So that's why they are immobile, and the chances, the risks of injuries are more compared to the lateral meniscus, which is not rigidly attached to the lateral collateral. The lateral meniscus, the normal, we have the anterior, posterior horn are almost equal in size, the body being the largest portion. And in the posterior horn, it comes high up over the tibial spine to insert near the PCL in the normal anatomy. This is again, we have the spickled or striated appearance of the interior horn of lateral meniscus. It's of normal appearance due to the insertion of the ACL fibers into it, and it should not mimic, of course, tear. The variants that can mimic a tear will go through it. First of all, we'll start with the meniscal flounce. It's a single fold, undulated fold, which is seen in the free edge in the inner margin of the body of the meniscus. It happens when the patient is flexing the knee, and it disappears totally on full extension. It's a fold which has no abnormal signal, no cleft, so it never mimics a tear. And then you have the meniscofemoral ligament, the ligament of Humphrey and ligament of Frisbeck, just adjacent to the PCL. It can mimic a tear if it's seen on sagittal or peripheral tear in the posterior horn of lateral meniscus. For the anterior transverse intermeniscal ligament, it's a frequent anatomical structure that we see. In the Aggsr, if you can see, it's extending from the leading edges of the anterior horn of medial to the anterior horn of the lateral meniscus. In the sagittal, it's a separate one from the anterior horn here of the lateral meniscus, and you should not mistaken it as a horizontal tear. The less frequent, which we see in the oblique meniscomeniscal ligament, which is here extending in the axial normal structure from the posterior horn of the lateral meniscus to the anterior horn of the medial meniscus. And on sagittal, if you see it just in one plane, it can mimic a displaced meniscal fragment. The fluid in the popliteus recess, almost all the patient we see this peripheral high signal like fluid mimicking and like oblique tear in the posterior horn of lateral meniscus. However, seeing the sagittal and axial, you see this is the normal synovial fluid. Recess fluid. So how do they present off? They can present with pain, swelling, non-specific stiffness, popping sensation. The most common presentation is a locked knee, a stuck knee in case of a displaced fragment, giving away knee, difficulty in bending and straightening the leg. So to characterize the tear, they are of fluid signal, abnormal high signal, which should extend to the superior or inferior articular surface this is in two different patients. It's basically a rupture fragment of the posterior horn, either of medial or lateral meniscus, which comes and lie adjacent to the anterior horn. So the anterior horn.
Lateral meniscus in 96%. However, MRI imaging is limited particularly to detect small posterior horn tears or involve less than 1/3 of the lateral meniscus. Maybe all of us have already know about this classification, but Lotis et al. Report MR imaging grading system for abnormal high meniscal signal intensity. Grade 1, we look small focal area of hyperintensity, no extension to the articular surface. Grade 2, we divide to grade 2A, 2B, and 2C. In 2A, linear abnormal hyperintensity with no extension to articular surface. Grade 2B, abnormal hyperintensity reaches the articular surface on a single image. 2C, globular wedge shape, abnormal hyperintensity with no extension to the articular surface. For grade C, abnormal hyperintensity extend to at least one articular surface, can be superior or inferior surface. Grade 1 is always normal in arthroscopy finding, but some grade 2 abnormal meniscal signal were found to be associated with a meniscal tear on arthroscopy. Dallon et al. Said that 50% of patients with grade 2 had meniscal tears on arthroscopy. Grade 3 is referred as a definitely meniscal tear. This classification of tear, there are 4 basic shapes: vertical longitudinal, vertical radial, horizontal, and oblique tear. Vertical longitudinal tears parallel to the long axis of the meniscus, dividing meniscus into inner and outer part. Vertical radial tears perpendicular to long axis of meniscus. Horizontal divide the meniscus into a top and a bottom part. An oblique tear starts as radial tear but then curve into longitudinal orientation. Classification of displaced tear. There are complex tear, combination of basic shapes, bucket handle tear, displaced longitudinal tear, flap tear, displaced flap fragment result from horizontal tear, parrot back tear, and root tear, radial tear located in the meniscal root. This table has almost showed that almost complete meniscal tear with each type and the complex tear have to have so that almost unstable condition and high clinical prevalence that frequently require surgery treatment. The treatment for meniscal tear is when a tear is identified, accurate description of its morphology and tear pattern is critical for treatment planning. Arthroscopy in meniscal tear is effective outpatient surgical procedure to ensure patient's meniscal tear and repair the torn meniscus by a variety of minimally invasive technique. Arthroscopy being highly sensitive and specific procedure, both diagnostic and therapeutic, but is invasive. The first goal of meniscal tear is classification. Horizontal intrasubstance tear or degenerative tears without mechanical symptoms can be treated conservatively. Non-surgical therapy divide resting, icing at regular intervals, compressing and elevating, and SID and physical therapy for reduce of movement and general strengthening. In surgical treatment, divide into excision, partial meniscectomy, remove as much unstable torn tissue as possible, but leave behind as much normal. Meniscal tear MR compare with the arthroscopy finding. Case 1. Male 27 years old with left knee pain after twisting his left knee while playing futsal 3 weeks previously. Physical examination, Lachman test suggesting an ACL tear is positive and medial joint line tenderness. The fat saturated weighted image in sagittal view show a horizontal hyperintensylation of medial meniscus that one slice so that reaches articular surface. Is associated with an ACL tear and bone breach in posterior tibial condyle. And the coronal view show ACL tear and horizontal linear hyperintensity in the periphery of medial meniscus. In the coronal view, we can look the linear hyperintensity is not reach the surface. What arthroscopic finding? Arthroscopic view of medial meniscus show no tear on medial meniscus, but the tear showed in MRI extend to meniscal surface perforated only on a single view in sagittal plane. This corresponds with grade 2B Lotis classification that not always seen in arthroscopy. Horizontal intrasubstance tear is a stable tear, mostly non-symptomatic. Non-surgical treatment of this case of meniscus tear but ACL reconstruction. For case 2, male 27 years old complaining of right knee pain, giving away, and frequent episode of locking. Past medical history, so twisting his right knee when landed on the ground after jumping when he played basketball 3 years ago. Fat saturated weighted image in sagittal view showing ACL tear and double PCL cell. Finding is unstable tear which can cause mechanical symptom, locking and pain, location in white and red white zone, integrity of meniscus tissue is poor. So the therapy is ACL reconstruction and partial meniscectomy. For case 3, female 14 years old basketball player with history of illness, left knee pain and giving way after falling down and when she played basketball 6 weeks previously. From physical examination, we can find Lachman test positive, medial joint line tenderness and McMurray intensity test positive. How about MRI? Fat saturation weighted image sagittal view show longitudinal tear on periphery medial meniscus. Image 1 and image 2 and the associated injury in ACL 2. This coronal view show peripheral longitudinal tear of medial meniscus. And the arthroscopic finding is peripheral tear of medial meniscus, this. And then the tear is reduced and repaired using suture. For that case, MRI in peripheral longitudinal tear of medial meniscus and ACL tear, arthroscopic finding, suitable unstable longitudinal tear, location in red zone, good capability for healing, integrity of meniscus tissue is good. So the therapy is meniscus repair with ACL reconstruction. Meniscal repair in the setting of ACL surgery have better potential for healing than an isolated meniscus repair. Take-home message for this topic, meniscus tear are common injury. MRI is a modality of choice in detecting meniscal tears with high sensitivity and specificity. Not all types of meniscal tear is seen on arthroscopy and need to be treated. Detailed history taking, physical examination, and accurate interpretation of imaging study will be very important in establishing the diagnosis of meniscal tears, treatment planning, and prevent unnecessary surgery. Thank you for kind attention.
Thank you very much for your presentation. Our next speaker, Dr. Sigmar from
Assessment of osteolysis. The Knee Society has a scoring system, just like in the hip joint. These are assessed on plain radiographs generally, and the zones have been delineated on the available views. On AP, there are 7 areas on the tibial side and 3 areas on the lateral on the tibial side. The knee, however, there are only 7 zones, and these are only on the lateral radiograph. As I said before, plain radiographic assessment of osteolysis has been superseded by CT and or by MR. Next we come to the posterior condylar offset. This is the vertical distance between the posterior cortex of the femoral shaft and the posterior most margin of the femoral condyles. And you can imagine if PCO, which is the posterior cortical offset, condylar offset, if that is shortened, then during flexion, the posterior margin of the tibial prosthesis will impinge on the posterior surface of the femur. And this will cause posterior knee pain and limited flexion, which is obviously not acceptable. In the assessment of polyethylene wear, there's a lot of the designs do incorporate some form of an artificial material in between the metallic prostheses, prosthetic surfaces, both on the femoral and the tibial side. The polyethylene wear can be assessed by radiographs, and that is probably the most common way of assessing it. Other techniques, including gravimetric measurements, coordinate measurements, laser scanning, and micro-CT, are rapid